Please don't be too critical of my photos. I actually, since this talk will be very far less than the allotted time, I actually would like to take a moment to add to Dr. Goldberg's comments because I can't stress enough the importance of good photography, not only for looking your best at a conference, but also directly to your patients. So many of my patients ask to see their pre- and post-operative photos, and if they look like junk, the patient's going to pick that up. And so just as we do a good closure and we present ourselves professionally, we have to make sure our photos don't look like junk. In terms of equipment, a couple of things that we've found are helpful at Dean Clinic in order to be able to focus on good technique is I work at two sites. One is in the ophthalmology department where we have professional photographers, and so they'll do all of my facial photography for me, and they understand even better than we do everything Dr. Goldberg just highlighted. What we did at I also am part of the plastic surgery department where there are not professional photographers, and so that the two other plastic surgeons and I could get consistent photos, our photography team set up a room where the wall is painted blue, not expensive. The camera, cheap camera, is on a tripod, also not expensive, and the light box is also mounted high on a tripod. And that right there eliminates a ton of the guesswork. A $50 remote control for the camera to click it allows my technician to be up next to the patient doing the head position and getting it right, and then click the photo. So some very inexpensive accessories that really allow the focus to be on the composition of the photo, and that's helped us tremendously. To follow on some of the points of my previous talk, which were really geared at how to stay safe as an aesthetic surgeon, I'd like to talk a little bit about tumescent anesthesia. Tumescent anesthesia is a development in anesthetic technique that has transformed cosmetic surgery. It has transformed liposuction. It has taken large procedures out of the operating room and away from general anesthesia and away from the risk and the morbidity associated with it. It's had the same effect on our facial plastic surgery techniques, where, for example, by doing a facelift under tumescent anesthesia, I do all my facelifts in the office procedure suite with either no sedation or, one tablet of oral sedation, and that's it. In fact, most of my patients opt against it and just do it with no sedation. So, tumescent anesthesia was first published by Jeff Klein, a dermatologist, in 1985. You can imagine the amount of uproar in the surgical community when a dermatologist publishes a major game-changing paper on how to do things. This allowed body liposuction to be done awake with good analgesia. It reduced the mortality, and prior to tumescent, the major mortality risk was pulmonary edema because people would get fluid overloaded. Wetting solution was used under general anesthesia, and so people would get fluid overloaded. Now, tumescent anesthesia sounds great up to this point, doesn't it? But tumescent anesthesia can kill somebody. Let me repeat that. Tumescent anesthesia can kill somebody. So you have to know what you're doing with it. And my goal in the next less than 10 minutes is to teach you my simple surgeon's way of doing lidocaine calculations on every patient on whom you do tumescent to stay safe. And every patient on whom you do tumescent, you should perform lidocaine calculations. If you train a resident or a fellow, it's also a great way to beat on the resident or fellow and make them do it. Because they need to learn to stay safe every time as well. So now lidocaine toxicity has eclipsed pulmonary edema as the primary risk for liposuction, facelifts, and fat transfer that are done in a tumescent technique. The general idea is to use very, very, very dilute lidocaine, like 0.05%, 0.02%, 0.01%. And you may say, well, how does that give you analgesia? If I do an eyelid or take off a mole, sometimes even if I use 1%, that's not enough. Well, when you're doing procedures that are based in the fat is not very sensitive, and this tumescent solution is taken up by the fat and slow released, so you also get much longer duration of effect than you would expect with lidocaine. As you may also be wondering, well, if you're going to do a couple-hour facelift, how does lidocaine get you to the end? This is how. So let's talk about the toxicity for a few minutes, and I promise you, I'm very proud of myself. I put this whole thing together without a single pharmacological chart and not a single formula, because I'm not much of a mathematician. You may have seen on the opening slide, I'm finance chair and I'm vice chair of the board, and I deal with numbers all the time, but I'm still no mathematician. So this is the non-mathematician, non-pharmacologist way of doing this. First of all, lidocaine is metabolized by the cytochrome P3A4 system. So anything that's going to slow the liver down is going to prolong the half-life of lidocaine, and the half-life is important. Normal half-life is 90 to 120 minutes when it's intravascular. The fat is like a slow-release drug mechanism. So peak plasma lidocaine levels after you administer tumescent occur 8 to 12 hours post-procedure. Now combine that with what I just told you, that it can kill somebody, and you get an idea of what time of day or night bad things happen. So as plasma lidocaine levels get to 6 to 10 micrograms per milliliter, you get the early signs of lidocaine toxicity: lip paresthesias, headaches, dizziness, confusion, vision disturbances, and tinnitus. Now the patient is still treatable at this point if they recognize these things and go get seen. And many of these things are noticeable enough where your patient would be alarmed and go get seen. The problem is, you have someone who undergoes a facelift and fat transfer, and maybe you're doing it together with plastics and they do some body lipo, or you do a BLEF and a few other things. The patient also got a bunch of sedation, and so they're still sedated overnight and recovering. These are the people who get killed, because these things happen in the middle of the night because of the slow release, when the patient is sleeping and too sedated to have these things wake them up. If you're just doing tumescent for a 2-hour facelift and they're not getting any sedation, they'll notice these things. So at greater than 10 micrograms per milliliter, the catastrophic things happen: hypotension, arrhythmias. I mean, we use lidocaine when we run a code, when we do advanced life support. Lidocaine can do a lot of things to the heart: cardiac arrest, seizures. It's also a neurotoxin, comas, and respiratory depression. And once you get to this point, it's generally not treatable. So what's the maximum safe dose? If you pull out the drug label, it's 7 milligrams per kilogram, but that's plasma lidocaine, okay? We're taking the same amount of lidocaine and putting it in the fat. It's slow release. So in men, it's 35 milligrams per kilogram, and in women, it's higher. It's 55 milligrams per kilogram, okay? The modified Klein solution that I use is in the purple box on the top right of your screen. It'll show up in a few subsequent slides as well, so if you miss it on this slide, don't worry. The reason I like using this recipe is it makes the math easy. Everything is a multiple of 10 if you do this. Always measure the patient's weight before surgery involving tumescent. Never ask. Stick them on the scale. The other things that make the math easy is if we use this recipe and we load it up into 10 milliliter syringes, then every syringe has 10 milligrams of lidocaine per syringe. If you measure the maximum safe dose for the patient, each syringe is 10 milligrams, you can count it in your head, but even I prefer not to do that. Because this is really a kind of stupid way to hurt somebody. So we have a simple spreadsheet that we developed in numbers on the Mac, Excel on Windows. This takes like 2 minutes to put together, and then we just open a new one on the computer in the operating room every time we do a tumescent case, and we put in the patient's weight. In the US in pounds, it converts to kilos to do the calculations. And then concentration of lidocaine used in Klein solution, 2%. We used a 50 milliliter bottle, just dump it in, and 1,000 milliliters of normal saline. This is way more solution than you're ever going to use, but the contents are cheap, so just make a liter of it. This way your staff can dump one bottle of lidocaine in, and there's no opportunity for error. Okay, so the total lidocaine in the tumescent of 50 milliliters of 2%, if you do the math, is 1,000 milligrams. The way you calculate that, I guess I am going to give you one formula. I'm sorry. The milligrams in a bottle of lidocaine to convert from percentage to milligrams is the concentration times 10 times the volume, and that gets you 1,000 milligrams. Okay? So the lidocaine concentration in our liter of tumescent solution is 1 milligram per milliliter. Isn't the math easy? So each 10 milliliter syringe is 10 milligrams. Now, for this patient, who's 82 kilos, total safe lidocaine is 2,864 milligrams. We don't have that much in our solution, so we know we're safe, but we're going to do the calculation anyway, and we're going to count anyway. That way, if the patient does run into any untoward medical circumstances after surgery, we have documentation of the lidocaine we gave them, and we can show that we were safe. If you get a frail, small person with a low body weight, you can see where this recipe could even contain enough lidocaine to hurt somebody. Okay? So at 8 syringes, I've given 80 milligrams, and I'm not even close to touching the total safe lidocaine for this patient. Does that make sense so far? Okay. This is just another illustration of the tumescent anesthesia recipe. When I do a facelift, which is going to be the most common purpose for tumescent technique for this audience, I'm typically using about 4 to 5 syringes per side. And then it makes the face huge. You don't actually have to wait the 20 minutes for vasoconstriction because the fluid effect actually helps physically vasoconstrict the face also. So I'll tumesce one side, I'll tumesce the other side, and then usually just get started. And the second side that I operate will usually be a little more vasoconstricted than the first, but the vasoconstriction is excellent. I almost never have to cauterize anything when I do a facelift. As far as administering, I'm going to show you the video during my facelift lecture because it's the same video, and you'll see the tumescent technique then. The key is to put full-strength lidocaine along the incision line. That's where you need the skin and the subdermal tissues truly numb with some 2%. Okay, count that into your total lidocaine. And then once you've just put one strip of full-strength lidocaine along your ear incision, you can make a little stab incision with an 11 blade, slip your cannula in, and then just keep a wave of tumescent fluid ahead of the cannula. The patient will describe a pressure sensation, but they do not feel the burn of full-strength lidocaine. It's really amazing. When you see the video, you'll be shocked we do this on people that are awake, but they hardly feel it. So I'll show you this video later. And for now, that's it, and I'll pick this up in the facelift talk. Thank you.